Hello, everyone. Thank you for having me here. I'm going to apologise in advance that I'm not the person controlling the slide deck today. So as I present through my slides, there'll be a fair bit of Chris Whitty style. Next slide, please. But a big thank you in advance to the team who are controlling the slides. And I wonder if now we could go to the slide deck.
Shall, would you be able to share those, please? Lovely, thank you. I think you're just on mute, but that's okay. Yeah, I don't know if anyone's
I'm
noticed that we've
talking
got.
away, sorry. There,
That's
I was just
okay.
saying, just getting it up now.
Okay, thank you.
And let's just put it in full. And is that all showing okay?
That's
Thank
brilliant.
you.
Perfect.
Thank you very much. And yeah, grateful if you could put your mics on mute. And if we're ready, let's kick off. Next slide. I'm here today to talk to you about improving productivity, some approaches that can help. On the next slide, you'll see the structure of the session today. I'm going to be giving you a presentation for about half an hour. Please do put any questions in the chat, but also after that, I'll be stopping specifically to answer any questions. We'll then have some time in breakout groups and come back together to share some reflections. And before we kick off properly, if we just move on to the next slide, of course, it's incumbent on me as a Q member to say, please, if you're not a member, think about joining Q. You can look on the website or click on that QR code. So next slide, please. The starting point for this presentation today is really thinking about the productivity challenge that the NHS is having at the moment that's really shown by the blue line on this graph, which is healthcare productivity in England. As you can see, it took a big hit quite understandably during the COVID pandemic. A range of measures contributed to that, including social distancing and safety measures. But unlike the productivity in the wider economy, on the yellow line, you'll see it hasn't yet fully recovered. And there's a lot of head scratching going on about why that is. I guess this graph is flagging up a really important point, which is productivity can be looked at in a range of ways. It's an economic concept, and many discussions about productivity can seem quite abstract and high level. And indeed, sometimes that economic framing, I think, gives the idea of productivity a bit of a bad rap, not just amongst people involved in improvement, but among everyone who works in the NHS more generally. So before we get into looking at some approaches, I just wanted to kind of dispel some thoughts for a moment. What thinking about productivity and thinking about how to improve it shouldn't imply. So if you could click the first bullet, please. Very often there's a sense from people in the system, and it's a view shared by the Health Foundation that the NHS needs more investment. And to some extent, the pressures it's under are because of political choices about funding. Thinking about improving productivity should never be thought of as compensating for underfunding. And as an organisation, the Health Foundation's interested not only in how to improve productivity, but is advocating for a decent financial settlement for the health service too. The second bullet makes another point. Often when I talk to people working in the NHS and the term productivity comes up, there's a sense that it's kind of being aimed at the workforce. It's being aimed at people telling them to work harder. That's not what it's about in our view. It's about how we organise healthcare to optimize the way we turn our inputs into outputs. And we'll come on to that more later. But we definitely don't want it to carry that connotation. And then thirdly, another reason why it has a bad rap is that some of the steps governments have taken, particularly over the last decade, to try to improve productivity, have often been quite crude top-down measures, for example, pay freezes. These, in our view, are not sustainable approaches to improving productivity. And the productivity agenda shouldn't be really associated with those in the way that it has been. What's productivity about for us? Well, if you could click one more time, making sustainable productivity improvements is really about improving the delivery of care. And what I want to look at today is some of the ways that we can do that. Okay, so first of all, let's just start, and apologies if this is a bit abstract. What is productivity? Well, if you click onto the next slide, we see the equation. Productivity is output per unit input. And what this means is that we can think about a range of strategies for improving productivity. First of all, if you could click onto the next slide, please. First strategy is to think about how we change the inputs. If you could click onto the next slide, please. Thank you. Sorry, I'm behind. So if you could go back one slide. I'm sorry about that. So strategy one is to think about how we change the inputs to improve that ratio. Strategy two is thinking about how we can use the same inputs to generate greater output. Very often outputs are thought about in volume terms. But if we click onto the next slide, you'll see a very, very important point about healthcare productivity, which is that productivity is not just output per unit input, but quality adjusted output per unit input. There's no point increasing the volume of what the NHS is doing if it's harming quality. That's not a genuine increase in production. And so strategy three is to increase the quality of the outputs on offer. Now, at this point, I should just say that historically, the quality of healthcare marches forwards with developments in medicine and clinical practice in all of the individual areas that exist in healthcare. For that reason today, I'm not going to dwell on many of the possible ways of improving productivity by increasing the quality of outputs, but it's a very, very important aspect of healthcare productivity. We will touch on it a bit. Next slide, please. So let's try and move from the equation to healthcare. What might this look like in healthcare? And if we move to the next slide, this is just a visualization of healthcare production. Now, in some ways, this is a really terrible image in a way, a really terrible model of healthcare production. So I should just explain what I don't mean to imply, not implying that healthcare is a conveyor belt where we view patients like products or where staff feel they're on a treadmill. Nor am I intending to imply, of course, with this diagram that healthcare is about individual moments looked at in isolation rather than whole systems. But I'm using this crude diagram as a way we can look at the practical implications of that equation we've just looked at. So let's have a look. If this is a crude model of healthcare production, the first thing we could do is change the inputs to an episode of care, a bit like that. Then if we move on and we look at our model again, the next thing we could do is really change the efficiency with which those inputs are being converted into outputs, which I'm symbolizing here with a faster moving conveyor belt. And then that third way of improving productivity is thinking about how we're using that care episode to add more quality, though that's what our nice orange patients are showing there. So that's really how we could map that equation on thinking about, in a very basic way, an episode of care. Next slide, please. So now I want to think about some of the different approaches we can take to doing that in practice. And the first is skill mix change. Next slide, please. So almost 2/3 of the NHS's operational budget is spent on staff. So it's obviously clear that improving how people are deployed holds significant potential for increasing productivity. Traditional care models, in fact, if you go back to the previous slide, please, traditional care models like the one you can see here, this is symbolizing, have basically resulted in some staff doing tasks they don't need to, And perhaps more importantly, the skills of other staff being undervalued. In particular, many staff haven't been supported to develop their skills or work at the top of their skill set. So one type of skill mix change is to substitute one type of staff member for another. And if we move on to the next slide, you can just see that symbolized there. This can boost productivity by developing staff to undertake tasks traditionally undertaken by higher band colleagues. And there are many successful examples of this kind of substitution. Nevertheless, quality and safety really have to be at the heart of this kind of skill mix change, as there can be risks when transferring staff with less training, transferring tasks to staff with less training. And just to give an example, in fact, before we talk about that, there's plenty of evidence how over the last 20 years, replacing registered nurses with lower skilled staff in hospital settings has potentially harmed patient safety in some examples. So quality and safety have to be at the heart of this. Nevertheless, there's many kinds of successful examples. And on this slide, you can see a case study. So children and young people who are prescribed medication for ADHD need regular physical monitoring. And this has traditionally been performed in specialist CAMHS clinics, but that's not always convenient for families. And CAMHS teams around the country are struggling with staff shortages. A few years ago, the Health Foundation worked with Sussex Partnership NHS Trust to train local community pharmacy staff to provide that physical monitoring, hoping to provide both a more convenient service for patients and to free up time and resources within CAMHS services. Sure enough, an internal cost impact analysis showed that for a typical stable patient, having community pharmacy staff perform physical monitoring was about 40% cheaper than it being done in a CAMHS clinic. And they successfully implemented this type of skill mix change. The evaluation showed it not only freed up specialist clinical time in CAMHS, but it led to an increase in the number of patients engaging with medication monitoring and receiving care closer to their home too. So a really good example of benefits for the system and benefits for patients too. Now that's one type of skill mix change, substitution. If you move on to the next slide, we can see I'll present another comparison. Skill mix change can also boost productivity in a different way by adding to the range of knowledge and skills within a team. And you can see that visualized here. The idea is that if we can add to the range of knowledge and skills in a team, can improve performance. It's not simply about transferring tasks between staff, but really getting the most effective mix of skills and team working in place. Like that. On the next slide, we can see a case study of that. This is an evaluation of a trial in Canada, which added a pharmacist into a primary care team to improve the management of patients with type 2 diabetes. Basically, patients would get an initial review and examination from a pharmacist who would then make recommendations to the prescribing doctor. And also, the pharmacist would have a follow-up period where patients would be contacted to address any issues with medication management. The evaluation showed even though the pharmacists cost more, adding them to the team was cost effective because of the value they added. It significantly improved blood pressure control, reduced cardiovascular risk, and in fact was marginally cost saving as well because it resulted in lower complications and hospitalizations. So that would be an example of skill mix where you're adding to a team. There's loads of examples, as I've said. On this slide, if you click through, we can see a few, particularly greater use of allied health professionals, roles like advanced advanced nurse practitioners, for example, to examine patients presenting with particular things rather than doctors. In dentistry in the UK in a moment, there's a lot of thinking about the role of therapists and hygienists. I should also say before we move on, skill mix change does present various kinds of implementation challenges. I've flagged a couple of successful examples here, but there's lots of cases where it goes wrong. What are some of the kinds of challenges here? Staff need training and support if they're to perform new roles well. A particularly important thing also to flag is the importance of role clarity. If there's confusion about the scope of roles, that can reduce productivity. It can harm ways of working. Similarly, everyone needs to be on board. If skill mix change creates professional tensions, it can harm team dynamics and again lead to reduced productivity. What's the answer to all of this? Well, it's essential to involve staff in designing new working arrangements and providing clarity about the scope of new roles. Okay, let's move on to a second type of approach that can improve productivity by altering those inputs. and that's automation. Basically, technology can alter the inputs to a healthcare activity in a range of ways, and in doing so, it can increase productivity. And automation is just a simple example of that. It can free up staff to focus on areas where humans add more value. We could almost look at automation as a kind of radical kind of skill mix change. So if you move on to the next slide, again, we can see that visualized in terms of our crude model of healthcare. This is our steady state, but if we automate something on the next slide, you can see the practical effect of that, freeing up a member of staff who is now going off and working on something else. On the next slide, you can see a case study of that. Actually, this one's not about direct care provision, but I thought it was a really nice example. This is from the Health Foundation's improvement programs. And this was a project which was run at Imperial College Healthcare Trust. And it was developing a natural language processing tool that could help analyze the friends and family test. I don't know if you know the friends and family test. It helps patients give feedback to providers and commissioners. But the form includes a free text field. And that creates the issue that, on the one hand, it can provide really rich data to guide improvement, but the data in free text fields tends to be underutilized because it requires lots and lots of time to analyze it. Well, this natural language processing tool could analyze these unstructured text comments and summarize the results. And basically, the tool could analyze 6,000 comments in 15 minutes, which compared with 4 days if the same analysis was undertaken by a member of staff. That then freed up the patient experience team to spend that time actually acting on the patient feedback and improving services. So it's a really nice example of automation improving productivity. If you click on the next slide, we can see some examples of automations that are being talked about at the moment. A lot analysis of images and test results. Sometimes that's in a supportive way, but in areas like radiology, for example, there's exploration about whether an AI image reader could be one out of a pair of readers, freeing up a radiologist. Symptom checkers would be another example of automation. The one I want to emphasize the most is the bottom one there. Support with admin. Something we've been banging on about at the Health Foundation a lot is how technologies to support administrative and operational work are relatively neglected in terms of the central support provided by governments and system leaders. There's a lot of focus on cutting edge clinical tech like surgical robots and stuff like that, which is all very exciting. In fact, a recent survey the Health Foundation did of clinical staff found that the technologies staff said were saving them the most time were actually technologies to help with administration, communication, often very mundane things. But it's really, really important that we've got more focus on supporting the use of these technologies to help with administrative and operational work. To give you an idea of the scale of the opportunity, there was a study at the University of Oxford a few years ago which estimated that just over 40% of administrative work in primary care could be either mostly or entirely automated. Now, that was an estimate, but it's beginning to show the kind of potential scale of the opportunity. If we move on to the next slide, we can see some of the common implementation challenges you get in using automated solutions. Obviously, staff need to be trained not just to use the technology, but to oversee it and to avoid use complications like automation bias, where people put too much trust in the outputs of automated systems. Using technology successfully requires redesign of roles, processes, and ways of working. It's not just about the tech, but that whole set of change. And another key aspect of using technology is how you're going to ensure that care remains person-centered and that the tech is not squeezing out the human dimension of care. Now let's move on to think about a third potential way of changing the inputs to a healthcare process, and that's patient activation. Healthcare is not a product, obviously, it's a service, and outcomes are necessarily co-produced with users. And what that means is patients are always involved in their own care. And the question is how they can be supported to contribute as effectively as possible, particularly for people living with long-term conditions who are only in contact with health professionals for a small fraction of their lives. I should say before we move on, actually, that As a term, patient activation technically describes the knowledge, skills, and confidence that a person has in managing their own health. Here I'm using it as a shorthand to refer to interventions that can increase activation, like self-management support, health coaching, shared decision-making, peer support, and so on. If we move on to the next slide, we can see a couple of ways that patient activation could alter the inputs of a process. Now, firstly, on some occasions, there may actually be a shift in activity from staff to patients with staff capacity freed up. So if you click onto the next slide, you can see that kind of substitution represented here. An example would be, if you go on to the next slide, examples aren't that common, but here's an example, shared hemodialysis. This was a project the Health Foundation supported a few years ago, led by Sheffield Teaching Hospitals. Basically, hospital-based hemodialysis treatment can become a major part of a patient's life for someone needing it. Several hospital visits can last hours, and it can sometimes leave patients feeling demoralized and disempowered. And this project, called Shared Hemodialysis, aim to help patients become more active partners in their care by training those who can to perform key hemodialysis tasks, like checking blood pressure, preparing the machine, inserting needles, and so on. Involving hemodialysis patients in their care has basically been found to improve motivation and confidence and well-being, provided they're supported to do that. And the interesting thing about this project is it freed up nurses then to focus on patients who needed more support. So it's a really good example of how patient activation can help free up staff time and optimize the use of that staff time. If we go on to the next slide, perhaps a more common way in which patient activation can alter the inputs to a healthcare process isn't about substitution, but addition. And you can see that in the next diagram. Here, patient activation is improving productivity by increasing the effectiveness of healthcare interventions. So that quality aspect as well. And it could increase quality through better self-management of conditions, through increased medication compliance, better preparation for operations. And if we go on to the next slide, that's the case study I've picked here. This was a Health Foundation project a few years ago, where we supported a team at Manchester University NHS Trust to develop what's called the IRAS Plus Prehabilitation Programme. This is a pre- and post-surgery training programme that aims to equip patients to prepare and recover from major surgery in order to try and help reduce complications and length of stay in hospital. Among other things, it involves training patients in exercise, nutrition, and lifestyle advice, as well as a step recovery programme in hospital. It was trialled, first of all, with 1,000 patients at Manchester Royal Infirmary, and the initial evaluation showed it led to a reduction in complications and length of stay as well. And similarly positive results have been found in the evaluation of the rollout of this programme at a larger number of trusts, with high patient-reported satisfaction as well. So it's a really good example of how engaging patients more is helping them be partners in increasing the effectiveness and quality of a process with reduced complications and length of stay. Here's some examples on the next slide of common ways of increasing patient activation, self-management support. There's a growing evidence base on all of these. So self-management support, particularly for asthma and cardiovascular disease, peer support in areas like mental health and coronary heart disease. There's good evidence that shared decision-making can lead to patients being less likely to choose intensive treatment options like surgery and maybe more conservative approaches like physiotherapy. So you can see how all of these can potentially alter the productivity of healthcare processes. Just to finish on patient activation, let's similarly review what the challenges are with doing it well. A lot of these approaches don't necessarily require major funding, but they do require a willingness to work differently and to value patients as active partners in their care. And national bodies have an important role to play in supporting local systems to do this well. We're seeing a range of initiatives. I'm thinking of NHS England here, things like the NHS Comprehensive Model of Personalised Care, National Academy for Social Prescribing, and so on. We're seeing some of that support begin to come through. And finally, before I move on to our last area, I just want to flag an issue with all three of the approaches I've just reviewed: skill mix change, patient activation, and so on, that free up time. And we've looked at the challenges of making them work, but there's another really deep issue. And that is that if time is freed up, planning for the reuse of that freed up time is essential. You'll only get the productivity benefits if freed up time is used as intended. And it's not something that should be assumed. It's often assumed. Here's a slide from the Topol review in 2019, which was looking at the prospects for technology to revolutionize working practices in healthcare. And here's a kind of assumption that hours freed up equates to an extra number of staff providing patient care. But as you can also see on this slide, there's many different calls on the marginal hour of those who work in the NHS. More patient care could be one, but there's all kinds of other things ranging from management work, admin, research, training, QI work, and reducing overtime too. So a really important point about all three of the approaches we've just reviewed is when time's freed up, the planning for the reuse of that freed up time is essential to actually deriving those productivity benefits. I want to finish by going on to a fourth and final area. Now, the three areas we looked at so far, skill mix change, automation, and patient activation, were all about altering the inputs to a healthcare process. But you remember another approach that we could take was thinking about the efficiency with which those inputs are converted into outputs and improving the processes for doing so. And improving flow is one of those, particularly improving the flow of patients along pathways. So again, if we go back to our diagram, and you can see I've tried to kind of illustrate that with that sense of the conveyor belt speeding up. What is, and if you click onto the next slide, we can see that. What is improving flow about? It's about the better movement of patients' resources and information along care pathways. A range of different approaches exist for improving flow, of which probably the best known in healthcare is the lean approach, which was developed from Toyota in the mid-20th century. If you're not familiar with flow improvement techniques, they basically involve stripping out unnecessary actions or movement or waiting from processes and trying to apply insights from queuing theory to improve throughput. For example, reducing variation in demand, or maybe better matching your own staff capacity to demand. To make this less abstract, let's look at another case study. If you move on to the next slide, you can see quite a famous one here that the Health Foundation was involved in. This was a decade ago now. We funded a team at Sheffield Teaching Hospitals to evolve an approach called Discharge to Assess. Basically, analysis of their own care pathways had identified a cohort of frail older patients who were medically fit, but not able to go home because they were waiting for an assessment of their social support needs. What Discharge to Assess did was basically to flip that traditional discharge model on its head. So patients left hospital as soon as they were medically fit to do so. Then they had their support needs assessed at home. And this both enabled quicker identification of the right level of home care and support, but obviously it also freed up hospital capacity. In the evaluation that was initially done at Sheffield, what they saw therefore was a reduction in length of stay with no observed change in readmissions, which was obviously a key metric for making sure that quality wasn't adversely affected. I think they actually found that assessing people's needs in their own home in many ways worked better to assess that in the environment where someone was actually going to be living. So there would be an example of a flow improvement approach. If you move on to the next slide, we can see some examples of opportunities that are being talked about a lot at the moment. One is operating theatres, where it's estimated that around 2/5 of theatre lists don't run to capacity due to late starts or slow turnarounds or early finishes. Another recent major focus for flow improvement has been emergency care, not just the back door with hospital discharge, but also the front door as well, trying to get people early access to a senior decision maker. And then increasingly, with the advent of integrated care systems, we're seeing more and more attention turning to flow across whole pathways and systems. And before we move on as well, I should flag that we were looking at automation before and technology in the context of automation, but technology is also highly relevant to improving flow. And sometimes where technology is being deployed, it's not automating a process, but it's being used to assist staff. And sometimes the benefits of that assistance are speeding up processes. For example, faster data analysis, or in the survey we did recently, actually the top technology that staff picked that was saving them time were digital messaging apps to communicate with each other. By speeding up communication, they were helping speed up processes. There are various challenges with doing flow improvement well. It needs detailed diagnostic work. This is often not the kind of thing where you can just lift and shift interventions like discharge to assess. Rather, providers need the right capability, the right methods, the right tools to be doing that diagnostic work. And what we see from successful examples of flow improvement is interdisciplinary working and collaboration is essential for doing that well. So there we go. We've looked at 4 types of improvement approaches that can increase productivity, either by changing the inputs to processes or the efficiency with which they're converted into outputs. Sometimes increasing the volume of output, sometimes like with patient activation or adding to skill mix by increasing quality as well. What I'd like to do now is pause and take any questions before moving to some breakout groups. Without further ado, let me stop talking and ask, I haven't been able to monitor the chat in real time. Have we had any questions coming through? Or if not, would anyone like to pose a question now?
Yeah, we have had one question, Tim, that Paul has posed, which is understaffing the real issue, or is current staffing being bogged down by unnecessary manual overheads a bigger issue, exacerbating retention?
Yeah, it's a really, really good point. In thinking about how to maximize productivity, we need to be sensitive to ways in which the environment in the NHS at the moment might harm productivity. And that can happen at all kinds of levels. So first of all, if you're an organization with struggling with retention and having lots of staff churn, that can reduce productivity because, of course, new staff need to get up to speed and to build familiarity. But understaffing as well is another really, really important issue. Many of the approaches I've been setting out here are, I guess, examples of types of innovation in how we do processes. And doing innovation well, as I hope I've tried to flag when I'm talking about the implementation challenges, requires careful work, and it needs the right capacity to do it. It needs proper staffing. So technology, for example, it can't be a way of compensating for understaffing. You need the environment to be right to implement technology well, and that will you'll struggle to do that in an environment where there's a lack of appropriate staff. When I think about the wider economy and productivity and innovation, what economic studies show is that innovation can often be harmed once businesses' margins are squeezed to a certain extent. And I guess there's a public sector equivalent to that, which is that if healthcare providers are in firefighting mode or suffering from understaffing, it's going to be harder for them to implement effectively some of the approaches that are needed to improve productivity. So, Paul, I fully agree with what I'm imputing to be the sentiment behind your question. I see we've had another question through from Amina. Any advice or tips on how to improve staff training for the purpose of skill mix? Sometimes, even though a group of staff receive the exact same training, their productivity can vary widely. That's undoubtedly correct. And what it's flagging up is that whilst training is important, it's not necessarily about the training delivered in isolation to the individual. It's about how they're gelling with the team as a whole. And that's precisely why it's really important to ensure that skill mix changes are co-designed with a whole group of people that are going to be involved in making the new arrangements work. And that all the members of the team feel that they understand the role definition and new ways of working well. You can't just put it on the shoulders of the one individual, say, that's taking on the new task. There might also be differences amongst individuals. So I've seen many examples of skill mix go wrong because people haven't wanted to do them. Sometimes some people might, sometimes others might not. And when you scratch the surface, there might be a range of reasons for that. For example, people feel that it was a particularly important aspect of their job and they don't want something taken off them and given something else, etc., etc. So it's really important to have that broader conversation about how changes in skill mix are supporting people's development, supporting their vocational motivations, and what they want to achieve in the workplace. You know, that's going to be the key for kind of unlocking the goodness of that.
A few red blobs. And we just...
Great, thank you, Sophia.
So,
yeah, thank you, Tim. This is really useful. Revisiting some of, you know, the information I've had over the years. I guess it's more of a reflection, but there's a challenge in it, I think, is we do sort of land up in this zone of productivity going into performance very quickly and productivity viewed as performance. And we've tried to flick it at our end. We are a mental health trust and we've been looking at time to care and the big piece of work that primary care had done on time to care. We've used some of those principles in bringing time to care. So there's two elements happening alongside a process, improving flow of the process, but also improving people's own ways of lean working. And it was more of a reflection that actually by doing the two together took away some of the performance bit when we were looking at time to care kind of motion studies, time motion studies for staff to look at how their own individual practices can become leaner, which goes back to the earlier question from Amina in terms of the productivity for individual people and taking that off, but being very careful in the background that actually leads into a conversation of performance management. And I think as a team of improvers, you've got to be prepared with that scenario coming on quite quickly on because you're in that zone of performance. It's more of a challenge of how do you overcome the two alongside.
I absolutely agree with that. In many ways, even though I've been talking about the concept of productivity, I don't find it's a helpful concept to frame change initiatives often, precisely for the reasons that you highlight, Sophia. And there's partly why it's so good talking with Q about this. What I've tried to be flagging in what I'm presenting is that there are actually deep links between conceptual ways of thinking about productivity and some natural improvement agendas. And I often find that it's the kind of improvement frame that's a much better one to be engaging staff with. So, for example, skill mix change is ideally about someone's career development and how they can be supported to develop and progress and work more at the top of their skill set if they want to do that. Automation, hopefully, is something that is freeing up staff from stuff they get less enjoyment from to do stuff they get more enjoyment from. Improving flow is often about stripping out some of the things that frustrate staff, not just patients. So I believe there is an improvement lens for all of those techniques we've talked about, one that much better speaks to the well-being of staff, the vocational motivations of staff, and the ambitions that we've all got for the health service. And I would find those a much more useful frame to be engaging people with than the notion of productivity per se.
Yeah, and just to add, I think within the health sector, we very quickly going to go into cash releasing schemes. And I think the cash releasing again goes back into saving money, but losing a very big element of staff productivity, improving quality against sort of the the money and the time. And
Yes.
Taking it as a triangle, I always think you increase or reduce any one of your spokes of your triangle, you will have an impact on the other two. And it's about how do you manage the other two without having an impact on the third. So I think
Yes.
cash releasing schemes are the victims of the health sector.
Yeah, I understand, and obviously there's big pressure to try to release cash at the moment. It's really important to say that the notion of productivity doesn't imply that. It's about improving the ratio of output per unit input. It's not just about cutting inputs. And indeed, sometimes cuts can harm that ratio. They can harm productivity. So whilst it can have clear advantages if improvements in productivity can release cash savings, that's not necessarily a starting point for many of them. And again, I think that notion of improving and adding quality is really, really important. Now, we blocked out a bit of time in this session, perhaps just to step back and have some chats in smaller groups. The question I wanted to pose to everyone is, of all of the stuff I've been talking about, is there anything there that has resonated with you in terms of either opportunities you're seeing in your work, or maybe frustrations? Maybe there's kind of dissonance between what I'm saying and what you're seeing in your work. It would be great to hear that. So what I wanted to suggest is maybe we just have a few moments breaking out into smaller groups, and then just come back together to share any final thoughts or reflections. I hope that sounds okay. In which case, I'm going to ask Katie to press the button and move us into breakouts. Thanks, Katie.
Brilliant. Should be moving in shortly. And then we'll bring you back in about 5 minutes. Thank you.
Well, hello, everyone. It's nice to see you back. I hope you had some interesting conversations. I just wanted to allow a moment before we wrap up for people to share any further reflections or issues that had come up in those breakouts. Does anyone want to offer any? If so, now's your time.
Amina, do you want to come in?
Yeah, I'll come in. So we had a really good, well, thank you, first of all, Tim, for an excellent presentation. It couldn't have been worded better, and it so resonated with all of us. I think we all kind of found something to relate to in those slides. The things that resonated with us were slightly different. So the common ones were patient activation. So having patients, being responsible for their own care and contributing to their own care. Improving flow was a big one as well. And some people were with some people, staff skill mix particularly resonated with them. The main challenge that we kind of all agreed on is funding at the moment. Training, it's a vicious cycle. Sometimes training requires time and requires funding, and it takes people away from the services, so that can affect productivity, and it takes time for the training to be used in practice as well. Automation requires funding, so we've all agreed that funding is the biggest barrier for us. Yeah. Let me know if I've missed anything, Elaine, Dean and Barbara.
No, it's a really good point, and it's a point that at the Health Foundation we're often keen to make to policymakers and system leaders. Often it's for want of quite small amounts of resources to support change, for example, training, change management support or evaluation support or something like that. It's often for the want of those that potentially big opportunities aren't being unlocked. So what you say makes a lot of sense. Were there any other comments anyone wanted to offer?
We just talked about the use of, so you talked about productivity will only be realised if there's a plan for reuse of freed up time, and we talked about the challenges around doing that properly, so staff don't feel even more apprehensive that they're going to get more work to do if things don't go to plan. And that's something a couple of us spoke about in our group, about who've witnessed that and the kind of anxiety which comes with that.
Yeah, it's a really interesting point. Did you have any solutions or advice?
Well, I'm not sure we got to that point. I think it is discussing it with the teams first and giving them the freedom. But I think sometimes when we start looking at productivity and we're saving an hour here and an hour there, sometimes there is the teams just wish to be able to spend more time doing the job they're doing. So it's a balancing act. And I think it's a difficult one to manage. And I think it probably has to be on a team by team basis. But certainly one team who I worked with, they did loads of they were a clinical team, but they were doing loads of admin and they freed up loads of time doing that. But they wished they hadn't really told anybody because there was huge expectations on them to
Sure.
do
It's
stuff after that.
a very political issue. I mean, one important thing to remember, just going back to that model of productivity, is freed up time could increase throughput and make the conveyor belt go faster in that terrible diagram I had. But it could also be used to spend longer with patients for higher quality consultations and add more value that way. That's also an increase in productivity. When I talk to people about this issue and people who work in the NHS, there is often a desire to have higher quality consultations and spend longer with patients. But yeah, it's a really difficult issue. And I guess my only thought is, given that there's a mix of ways time could be used, maybe there's a chance to work with staff. There's some kind of offer there about it not all being used for one thing or another thing, but agreeing together a mix that both delivers benefits of one kind, but also things that appeal to individuals as well. I guess there's some kind of offer there.
I think Paul has had much more experience of this than I have, but I think it is, and for me, it's when you're thinking from the start about how you're going to release that time, that increases the anxiety of the people just on its own. The fact that you're saying, well, we're going to release all this time and then we're going to do this, this and this as a result of it, that when staff are so already busy and overwhelmed, that's a concern. And it's about managing those concerns through, isn't it? So it's not saying don't do that, because absolutely you do need to understand how you're going to free the time up, but it's about how you do that and the conversations you have around that, so it's not adding further overwhelm onto staff.
Yeah, that makes a lot of sense. I think we've got time. Is there one more reflection?
Suzanne,
I can't find my hand. So I'm physically raising my hand because I can't find my button. No, I was just going to add to that. Really, we kind of illustrated that point. Also, certainly a role of mine at the moment as a pharmacist embedded researcher at Leeds is that we're looking at how we release time in terms of protect, because that also resonated with me, and finding people protected time to do things like research. And again, it being, if you're trying to release time for people, that it's not spent on doing, although it's clearly a great thing that they've got more time to spend doing their job better, that they find time to invest in something else, such as research, that might be something that's maybe not as well known to them, the outputs or the measures are not as clear or as an immediate. So there's lots of, it's quite complex, isn't it? But I just thought I would add that as an illustration, really, of the similar discussions that we'd had in our room, although we had many discussions.
Well, it's really interesting to hear about. And yeah, that I guess that process of trying to come up with a shared vision for how it will be used is the kind of key bit of alchemy that you need to make it work. I'm going to offer my takeaway just from reading the questions and listening to everyone today. Perhaps you let me finish with that, is the value of thinking about this from an improvement lens. I see in the chat someone flagged just more generally the importance of facilitating learning, spread, implementation of innovation. Providers need the improvement capability to do this stuff well, if it's to work. And as we discussed before, often improvement can be a more useful frame for engaging people than economic concepts like productivity. So for me, my takeaway is just not just a potentially strong synergy there is between productivity and improvement, but the advantages that an improvement lens can bring. Well, look, thank you so much for having me today. To finish, I'm just going to hand back to the team, who I think will just want to round the session off.
Yeah, thank you so much, Tim. I'm sorry that we ran out of time because I could see, Piers, you had your hand up, so apologies about that. But thank you all so much for your time. Shah is just going to put a survey up, and we'd be really grateful. It just takes literally like 20 seconds, 2 questions, and we'd love to hear from you. So thank you all very much for your time and all your contributions, and I hope you found it helpful and useful bit of time. Thanks so much. See you at another event soon.